Hey there, it's Wayfair here, where delivery and setup are as easy as a few taps on your phone. You're relaxing in an old hammock, scrolling Wayfair's app, when you spot it, a brand new patio set. Next thing you know, Wayfair delivers it right to your patio and sets it up. Oh, you need a new grill too? All right, Wayfair's got you covered. With Wayfair's Room of Choice delivery and fast expert setup on qualifying orders, life gets a little easier. Visit wayfair.com or the Wayfair app.
Wayfair, every style, every home.
It's now your job not just to be able to apply that knowledge, but also to be able to take a team through the application of that knowledge in a high stakes, must not fail moment. Right? And that's really the transition that we're talking about here between junior and senior. It's not just about you anymore. Now it's about the entire team around you.
Welcome back to Rebel Mind, where we sharpen the person behind the practitioner. Today we're talking about the mental jump from junior to senior and how to lead when the room gets loud. I'm Dr. Mark Ramsey, and with me is Dr. Dan Dworkis, an emergency physician, Chief Medical Officer at the Mission Critical Team Institute, and author of The Emergency Mind. He has his own awesome podcast, so definitely check that out. It's great for you to be here, and I'm so excited to do this.
Mark, thank you so much for having me, man. I'm thrilled to be here doing this with y'all.
Yeah, it's a long time coming, and I'm glad that we're finally talking about leadership transition, especially in the emergency department. Hopefully, by the end of this, you'll have a pocket playbook and a way to manage cognitive load and maybe even run the room and a few drills that you can start on your next shift.
I think this is a super important topic, right? And it's something that most programs, when we train folks, we have sort of an intuitive understanding that there's a difference between knowing the science and knowing the medicine and the ability to apply that science and medicine under pressure. And most of us already follow a pattern of graduated responsibility, right? We start off just seeing our one patient and we move into seeing a few patients. And then by the time we're, sort of a junior to senior leadership, we start really running a room. And I think that there's just so much in there, right? There's stuff that I'm sure you had your own method of learning this and teaching this. I have my own method of learning and teaching this. But I think that if we abstract that out a little bit, that skill set of transitioning from one level of responsibility to a higher level of responsibility, both in terms of depth and breadth, there's identity pieces that go with that. There's structural and tactical pieces that go with that. There's leadership pieces. It's just a really rich ground to dig into.
Yeah, and a lot of this is not taught or really explored deeply. And that's really why I wanted to do this episode, so that we can better understand all the different facets of it. I think, like you mentioned, there's so many things to unpack here, whether it's, leadership abilities, just people and interpersonal interactions, or even just task ownership, like so many different things that could be dived deep into. And I mean, like we could literally have an episode for each of those items, but like, why don't we start with just kind of like what happens when someone even just transitions into a senior leadership position, kind of, with your expertise about mindset, what are some mental shifts that you typically see?
Yeah, it's worth taking a slight half step backward and being like, when we talk about moving from junior to senior, like what are we really talking about, right? Because some of these things will be constant no matter where you're working. And some of these will be very microclimate dependent in large quotes, right? Like how does it work at your shop and your program and your situation? So there's a fundamental transition that happens when you're a junior. Your job is to learn the skills, right? To learn the skills and to learn about yourself. Basically, those are your two jobs, right? And the skills are anything, right? How to take a history and physical, how to splint, how to, start the basics of resuscitation, how to start an airway. And as you're learning those skills, you're also learning about yourself, right? How do I perform under pressure? What is it that gets me off track? How does my mind work? And how does my mind work compared to the way that the minds of my instructors and supervisors work? And there's sort of a self-reflective tuning process in there. And in some fields, that is the extent of your learning, right? Your job is to do the task, to make the pizza, to be an expert at doing your craft. But one of the things that makes emergency medicine so different and weird, and in my mind, fun, is that you don't stop there. You then go through this second transition, usually before you're totally baked at the first transition, right? And the second transition is some version of, now it's not enough to know the thing. You also are called upon to lead the field. And whether that field is your one resuscitation room or your entire section of the department with 20 beds or whatever it is, maybe your entire ER, right? It's now your job not just to be able to apply that knowledge, but also to be able to take a team through the application of that knowledge in a high stakes, must not fail moment, right? And that's really the transition that we're talking about here between junior and senior. It's not just about you anymore. Now it's about the entire team around you. And we force you to do that before you're really sort of totally cooked on your own skill set. So you're simul-tracking growing yourself and learning how to manage the team around you.
It's really important that you use the term force, because I feel like it's out of necessity, right? Because by the end of your intern year, right, when you're a second year, I've heard this term said a lot of times, is like there's now going to be somebody behind you that you have to show. And I think like all of a sudden you're in this predicament, or you're in the situation where you know how to put in these orders, and then all of a sudden there's now a, intern, or if you even will, like a medical student behind you who has no idea how to do any of these things. And so there's a necessity, if you will, to kind of keep the department going, keep the flow going of, let me show this person how to do it, and let me teach them, and kind of let me, guide them into this new process that I seem to have, for your words, half baked slash half mastered, half cooked, understood. And then that way I can maybe contribute to the overall moving forward of patients and flow and department.
Yeah, and it's uncomfortable, right? Like the junior to senior transition is uncomfortable. And if we do it right, it should be uncomfortable because we're pushing you outside the boundaries of where you are knowledgeable and what works for you. We're forcing you to adopt a different stance and take a different role on the team. And that can be very discouraging, frankly, because you spent your entire intern year being uncomfortable, not knowing, in the words of I forget who it was that said this, but basically not knowing your ass from your elbow, right? And like trying to like fumble your way through everything for that. And then all of a sudden, second year comes around and you're just starting to get your feet underneath you. You certainly don't know everything, but there are pockets where you feel comfortable. There's skills you've had. You're no longer the most junior person in the hierarchy. And there's a sense of not quite peace, but at least like, okay, now I can sort of concentrate differently. And then just when that's starting to feel good, like wham, like Mack truck to the side of the head here, now all of a sudden you have to lead a space at the same time. So one of the features that I think we can keep talking about is that what we're describing in terms of responsibility and in terms of demand on you as a human being is a step function, right? You start at one level, and then when you go through this transition, there'll be another step, and it's really just a step that you're going through. And from the I imagine we'll sort of alternate back and forth between the internal mind of the person going through this and the external system of who's supporting that person as we go through this, as we have this conversation. But if we shift to the external system, one of our jobs is to take that step function and turn it more into something that looks like a ramp, right? Where we are allowing you to have a graduated increase of pressure and responsibility such that you still have to make that transition, but you don't have to do it with quite as much of a jarring sort of punch in the face mentality about it.
Yeah, and in the medical education space, kind of what it sounds like you're describing is scaffolding, where you are building upon already existing learned traits or characteristics, and then using those, kind of similar to like a scaffolding of like a building when you're doing construction, where you're using that somewhat temporary structure in order to climb a little higher, or to fix something else, or to get to areas that you wouldn't normally need to. And it's interesting because without that structure, you wouldn't be able to necessarily achieve the finished product or the end goal. And so that kind of step, or that like ramp fashion, if you will, is necessary, but it's also important to realize like it's unsteady. It's not meant to be a long-term structure, and it's not meant to be a completely stable one. It's meant to be stable enough for you to complete the task or the job. And I think that's what makes it so hard, is that learners in that moment are realizing this is really difficult. This is probably temporary, but I need to get through this in order to achieve that end goal. So I think it's interesting, the similarities of that term and the ramp term you just used.
Yeah, that's a fascinating metaphor because I think that works really well when you're doing something like putting a central line in, right? So we're going to use scaffolding. We're going to teach you this skill at low speed. And there's sort of a, like a, in the military, they sometimes think about sort of like the crawl, walk, run phenomenon of it, right? But we're talking about, we're going to teach you how to do the thing. Then we're going to put you on a simulator. Then we're going to put you on a simple patient. Then we're going to put you on a complicated patient. Then we're going to be the delirious person with an INR of 6, right? And as we're doing that with no other vascular access sidebar who has a potassium of like a billion, like whatever it is, right?
Right.
Like make it as hard as you want.
Yeah. Yeah.
But scaffolding works really well in that circumstance because there is a sense of underlying knowledge of how something works. And then you're going to build on top of that to do the next skill set. Scaffolding is a lot harder to apply to this transition in particular because in some ways, most of us, as we're going through this process, have never actually been taught how to lead at all, right? We've never actually been
Yeah.
taught how to lead a resuscitation or lead a team. We've seen examples of it. We've been on the bottom sides of the hierarchy. We probably have internal models of what works and what doesn't, but we're really going from a 0 to a 1. And even though we're going to talk about sort of smoothing that curve, there's not a lot of foundation to build upon for most folks as they're going from this junior to senior transition point.
Yeah, I mean, it's incredibly important to highlight that we're not taught that leadership ability, right? Because there's actually a lot of things in medicine that we're not really taught that we're expected to perform and to do that's outside of the scope of like the medicine, right? That is, whether it's interpersonal relations and just, how to be a good human and how to communicate, but it's also, running a room and like resource optimization and utilization. Like that's just another one that comes to mind is like, you have to be able to have a pulse on the department and a pulse on like the CT scanner and like how often that's being used and things like that. And these are all things that aren't really being taught. And that's part of the reason why I started like Rebel Mind was to be able to have a space to communicate and discuss these kind of things for people who might not be getting it in their particular residencies or shops. So I think it's really, really important that we continue to bring to light the topics that aren't taught upon, because it's that like Dunning-Kruger effect of you don't know what you don't know, right? Like more and more of these topics seem to pop up.
Yeah. So if we can I throw out like a baseline skill or two that I think are super important for anybody making this transition, and then we can sort of build on top of that to think about specifics. But one of the first things that it's worth saying out loud here is that leading a room or leading part of a team working under pressure is a skill. It's not, in my mind, an innate character trait, right? So if it's a skill,
Agreed.
then it's a skill that you can and should train actively and get better at, right? And that's important because in medicine, and specifically in emergency medicine, we don't expect to get better through osmosis, right? If you and I are just standing next to a team doing a cardiac arrest, we don't presume that makes us any better at actually being able to take care of somebody with a sick heart, right? Instead, we go in and we learn the skills, we block and tackle, we do drills, and we do all of that stuff. So the same thing should apply to this skill. So to the extent that leading a room and leading a team is a skill, we have to be actively involved in learning it. Well, functionally, what does that mean, right? So first off, you should be asking questions to people that seem like they are good leaders in your field, right? Not just questions about the medicine, not why did you use amiodarone and not lidocaine there, right? Although that's potentially interesting, but instead, hey, I noticed that you structured the way you spoke differently than I've seen other people. Why did you do that? Hey, I thought that like the way that you worked with those nurses seemed to be particularly effective. They seemed to end this case happy and engaged. How did you do that? Right? One of the most powerful versions I've seen of this question is people who are like you, but maybe worse at leadership. What do you think they would struggle with in this space? Right. And that tends to open up just like this huge, and I totally stole that question, right, from Diane Chadwick Jones, who's one of the former VPs of BP, the oil and gas company, right? Like people that are like you, but worse at this job, what do you think they would struggle with? Man, like so many things in there. And you can ask a different version of that, which is when you think about leadership, what's something you do differently now than when you first started? And why did you make that change? But whatever question you use, right? The point is just go up to the folks that seem like they're good leaders and ask them why they're doing what they're doing. Now, maybe you got to keep asking, right? Because maybe the first person you ask is like, I don't know, I've always done it this way. Or what are you talking about? Everybody's a leader, or, sort of whatever it is. Like not everybody is equally good at teaching this skill set. But if you keep digging, you're going to find patterns and answers and tools that you can then think about applying. And it's really important as you're asking this to not just ask the leaders in the room, right? Go up and ask the experienced charge nurses, the folks who aren't technically at the top of the hierarchy, but have a depth of experience and a time frame in this field that dwarfs everybody else, right? What do you see when you see good leaders? What do you look for? What are some mistakes you see junior leaders making? Right? Just get curious about leadership as its own skill and start putting the sort of like pylons down that you're going to build your own personal foundation on.
Yeah, that's huge. And I kind of want to challenge you
Mm-hmm.
to help explain maybe to a learner or somebody listening to this how it might be in a psychologically unsafe culture or workspace, because I mean that seems to be a pretty hot topic of psychological safety and being, in a place where you can ask questions, and that when you do approach those leaders that you're describing,
Mm-hmm.
it's not met with like defensiveness, or it's not met with like, oh, you're just an intern or you're just a doctor. Like, you know what I mean? What advice would you give to listeners who might be in a little bit more of those toxic or malignant programs that don't have that kind of open culture or open, safe space to do that?
Sure. So, first off, I think it's worth saying that psychological safety is created by everybody on the team. Right now, certainly the leadership and the hierarchical structure has a disproportionate vote, but everybody is in charge of sort of creating it. So, if you find yourself in a situation where it's a lot harder to ask those questions, right? Then you got to think a little bit more laterally. So first off, let's just do some basic stuff. Make sure you're asking the questions at the right time. Okay, if you are in the middle of a resuscitation and somebody is dying, that is not the time to tap the leader on the shoulder and be like, "Hey, could you give me some advice about how I structure my open-ended questions? Is this a safe or appropriate time, not for me, but for the patient to be having this conversation?" Right? So you got to be careful to make sure that you're asking in the right way. One way around that, and this sort of gets to psychological safety and sort of understanding the pulse of the room too, is to ask the people who are not necessarily at the top of the hierarchical pyramid, but folks who are a little bit ahead of you about what they're looking at, right? That's often safer to do. Just, hey, what are you tracking right now? Where are your eyes when you're in this room? Like, what do you see as leadership? What are you working on and trying to get better at? Those are often much easier to have conversations than going to somebody who's at the top and being like, how do you become a leader, right?
Yeah.
The second thing is that you can almost always talk to folks who aren't necessarily the official leaders, right? Medicine is a hierarchical culture, but experience doesn't always track that hierarchy, right? So you can have a triage nurse. In fact, you often do have a triage nurse who is one of the most experienced people in the entire hospital. Right? In fact, that's usually why they work triage, right? We put them up front so they understand the difference between sick and not sick and whatever else. Those
Hmm.
folks aren't always thought of as official leaders of the team, right? So the sort of dynamics are a little bit different talking to them. But one of the best decisions I've ever made in every hospital I've worked at is to go to the charge nurse on shift and be like, hey, I need some help. I'm new here. I want to get better. I would love to check in with you later on the shift about how I'm doing and see if you see anything that I don't. Right? What are you looking at when you see folks come in? What do you wish your junior doctors had on board? What's something that you've seen be a good direction or a bad mistake? People are generally really inclined to share that kind of thing, right? You're not competing with these people. You're not necessarily, like above or below them in hierarchy. You're just trying to get better. And I think to the extent that you can have that as an open conversation, that tends to defeat a lot of the hierarchical, psychological, unsafe environment of it. The second half of that thought is the other side of the coin, really, which is that remember that as you start moving into this space, as you start making this junior to senior transition, you are also in charge of creating the sense of psychological safety. So it's a pretty precarious position to your point about scaffolding. Like you're a brand new leader and there's somebody who's it's their first day and they come in and they want to tell you something that's really hard for you to hear. All of a sudden you got to start thinking about how you're projecting yourself to the rest of the room as well. And just understand that whatever you think you're doing, you are probably creating less psychological safety than you think you are, right? You have to
Yeah.
go out of your way to create a space where people can talk to you. Even if you assume that you are a friendly, likable, open person, there's a good chance you don't actually come off like that all the time.
Yeah. Yeah, I mean, there's like so much to unpack there. I mean, the first thing about the charge nurses is huge, right? Every time I enter a new ER or ICU, or even when I'm like coming on shift, I always check in with the charge nurse, and it's just such a higher level leadership thing because you get immediate feedback about, just new information, right? And then the second point about how you address those coming to ask you questions is also huge, because it's that common advice that's often given but very underestimated, of like, keep in mind who's watching, and keep in
Mhm.
mind who's paying attention to you and everything that you do. It's almost unfortunate that it's like we're on stage all the time, but it's for the better and can be flipped to create a, culture of psychological safety when you respond to, even a medical student asking you a question, with the openness that you would another attending asking your advice for running a case. I think how you carry yourself and your demeanor in both of those situations is what sets the stage for psychological safety and helps create that kind of a culture of openness and being able to ask questions.
Yeah, so maybe it's worth getting really tactical about that for a second, right? So one of the things that you need to do when you are leading the room is you need to harness the knowledge and viewpoints of everybody else in there, right? The room is always smarter than any one person in it, to include you, right? The room is smarter than you are. So your job is to get those vantage points of everybody in it. Now, there's some global stuff that you can do about that, but for a moment, let's just get like super tactical. Like, how do you actually get everybody's opinion in the room about stuff, right? So there's a couple of things here that are worth just making very small changes in the way that you frame the questions that you're asking. So because there's hierarchy and because you're now going to be partly on the other side of it, there's a natural human tendency to go along with whatever the leader in the room says. Okay, so if you're like, Dan, here's my plan, all good, question mark, I am very likely to just be like, yes, or to not say anything or just nod, right? Because you've created a situation where there's a hierarchy of answers, a gradient of answers. It's easy for me to say yes or maybe nothing. And it's hard for me to say, actually, Mark, no, I really disagree with that plan. Like, I think we got to do this instead, right? So one of the things you
Mm.
can do as a leader to get around that is ask for contradictions, ask for disconfirming evidence, right? Folks, my plan is to intubate. What I need is information from everybody in the room about why that is not safe or wrong. So I'm going to go around the room. I'm going to look at each of you. What do you think is wrong with that plan? And then you're inviting folks around the room to sort of give you that opportunity to speak up and say, well, Dan, like, we don't have an IV. Maybe we want an IV in there first. Like, great point, Mark. We should definitely, like, yes, we do
Yeah.
resuscitate before we intubate. You are correct. I had forgotten that, right? Okay, cool. So now let's go solve that problem. But if you give them the chance, if you make it easy to say no, you're much more likely to get a diversity of viewpoints in there as you're doing that. And that's a really small structural change, right? So you're a junior doctor, you're listening to this, you want to be a better leader and a better senior. There's all this stuff about how do you do leadership in general. Fine. Here's a super concrete thing. Change the way you're asking questions from, do you agree with me, to, I need you to disagree with me. What do you think? Right? Very, very small. And you'll find the right wording that feels good to you for that. There's a similar process about that, which is that we find it harder to speak up when somebody above us has already offered an opinion, right? So whenever possible,
Mm.
can you ask for the opinions from the most junior or hierarchically disenfranchised people in the room first, and then and only then go to sort of the people that are more experienced or more formal leadership, right? So maybe that means, hey, we're running this cardiac arrest. I'm running out of options. I intend at the next pulse check to stop efforts, right? I think that we're out of ideas. What I want you all to do in this next 2-minute block of CPR is to come up with anything I'm not seeing. I'm going to go around the room and look at each of you and see who has an idea, right? This is our chance to make a difference for this person. Then when it's 2 minutes, you go around and you start by looking at the most junior person in the room, right? You clear the path for them. That's a lot of what leadership is. You're
Mm.
clearing the path for other people. So you make it as easy as possible. It's not easy, right? It's not going to be easy to speak up in that room, but you're going to make it as easy as possible by stripping away as much of the stuff, by giving the speaking stick, so to speak, to them first and allowing them the chance to speak up. You could imagine the opposite of that, right?
Oh, yeah.
You go to the most senior doctor in the room and you're like, got any ideas? And they're like, nah, we're done. Man, that is so hard to speak up against if you have some random idea
Yeah.
as a junior, right? And I have this very vivid memory of being a medical student and getting to watch a cardiac cath. And this was in the period of time where you could no longer throw stuff at medical students, but you could still yell at them, right? Like,
Sure.
and so, I was basically told, sit in the corner, shut the F up, don't say anything. You're lucky to be here. it was nicer than that, but I'm sure, but that's sort of how it came off. And
Yeah.
fine. So I'm sitting in the corner and I'm watching this cath, and I watch one of the wires break the sterile field and hit the table. This moment of like horror, right? Because like I know that wire has hit the table. And I also realize, oh man, I'm the only one in this room. Everybody else is looking where they're supposed to at the patient. I happen to be the only one who's looking off in the distance because I don't know what's going on. So I'm the only one that sees this. And now there's this ethical, moral quandary. Should I say something or not? Right? They told me to not say anything. What if I'm wrong? What if I screw up the procedure? But I'm pretty sure that's not sterile and it's about to go in that guy's heart. Does it matter? I don't know. Right? So you're creating this situation where that person who has a crucial piece of information for the case doesn't feel like they can speak up. Right? So
Yeah.
like certainly that's a story about psychological safety, but on the leadership side of it now, I'm always aware of the fact that there's probably somebody in this room that has a vantage point that I don't have. There's probably somebody in this room that sees something that I don't, that I desperately need to get that knowledge into the center of the room, right? Into our shared mental model. So how do I make it as easy as possible for that person to speak up and say something?
Yeah. Yeah. That's huge. Your story about the cath lab reminded me of, like, as an intern, I remember, being in the ER. This was in downtown Philly, and overhearing a police radio saying, like, 11-year-old shooting 2 blocks down or something. As an intern, I was sitting right across from the police officer, and the police officer's like, yeah, that's probably coming to you guys. And so all of a sudden you have an intern who has this like little tidbit piece of knowledge, may be true, may not be. They could be obviously diverting to a closer, more appropriate pediatric trauma facility. But at that point, I'm like, oh my God, like, what do I do? Right? Like, how do I even go about relaying this information? What if I'm wrong? Right? What if I assemble a whole trauma team and the patient doesn't come here? And I think it goes to highlight how important it is to pave the way for that junior person to speak up, essentially. I think it's pretty pivotal.
There's a whole bunch of research on the concept of high reliability organizations, right? Which are these structures that have very, very narrow safety bands of how they operate, where the product has to be exquisitely perfect, like 99.999% of the time, right? So like aircraft carriers, right? Or nuclear power plants, or to some degrees, hospitals. And one of the strengths, one of the methods that high reliability organizations use to stay so productive with such low error rates is they actively search for and try to highlight weak signals, right? Which is essentially what we're talking about. So as a leader, one of your jobs is to actively search for and surface what otherwise would be a weak signal, right? And this is, the med student that is the only one that sees the allergy bracelet on the person's wrist, right? This is the subtle like heart murmur that's maybe aortic stenosis that maybe you're not sure if you heard, and you have to slow everybody down and quiet them down to listen to it again, right? This is the little details like that, like, wait a minute, was that the right medicine at the right dose kind of thing? And it's your job to really surface those signals and make sure they reach the center of the room.
I'd be curious to hear how you can apply it to maybe a less critical scenario. I mean, you gave the example of a code situation where you're asking the team for ideas, but what about a routine abdominal pain or chest pain patient that presents in the ED, and you have maybe either a junior learner, or you have a junior learner who has a med student, or even just, a more senior learner, any of these individuals? How would you kind of go about paving the way for maybe the med student who initially saw the patient to speak up and be able to present that kind of perspective you may be missing?
Yeah. So if you're all right, I'll do shortness of breath instead of abdominal pain, because I think it's just
Great.
a little easier to sort of like
Yeah.
construct like that. But so there's two pieces of this that we can start applying in leadership right away. Well, one is to make sure the whole room understands the mental model we're using. Okay, so when I see a patient and I leave a room and I'm talking with my nurse or I'm talking with the rest of the patient's team, whatever it is, I will often try to say out loud, all right, I think what's happening, like my hypothesis is X. Like I think the shortness of breath is a COPD flare. Or I think that this is an allergic reaction, right? So first off, that's a great opportunity to then do one of those negative reflections again and go around the room and be like, does anybody see a different mental model that might also fit?
Mm.
Then you can go around the room and the other person can be like, well, I don't know. It seems like, doesn't the patient also have CHF? Like maybe it's a CHF flare. And then that's a great
Mm.
opportunity to be like, great question. How do we disentangle which one of these things it is? Because if we leave that room and one person thinks it's an allergic reaction, the other one thinks it's CHF, and the other one thinks it's short of breath because they have a, foreign object in their trachea or whatever, you're going to have different senses of what's happening. Your mental model of what's going on is different. Your expectation of reality is different. Your level of criticality is different, and you're going to really run into some problems there. So just being explicit, I think the problem is XYZ. Great. Now, can we have a discussion about that? The other sort of a quick way to do this, and this is kind of the second point, comes from David Marquet, who's a
Mm.
submarine captain, wrote this great book, Turn the Ship Around. In his second book, Leadership is Language, he talks about the concept of fist to five voting, which is essentially, all right, here's a plan or here's a belief. In a moment, I'm going to ask everybody to raise their right hand and show me a number of fingers, right? Fist, 0 fingers, is full stop. 5 fingers is full go, right? And any number of fingers in the middle there is some other thing. So I intend to intubate this patient. Is everybody like, how are we with this plan? All right. 0 fingers, this is a terrible idea. You will kill this person. Please stop. Right. 5 fingers, absolutely. That's what this patient needs. Let's rock and roll. And you basically count to 3 and have everybody vote. And what it does is give everybody a chance to surface their opinion at the same time, right? Which is a psychological safety metric. It also
Mm.
allows them to express uncertainty because instead of voting yes or no, you can vote 4 fingers. And you're like, well, wait a
Mm.
minute, Mark, why did you pick 4 instead of 5 fingers? What are you worried about? Well, Dan, I think it's a pretty good plan, but like, I'm a little concerned that they're under resuscitated and we need to improve it. Or I'm not sure we've really got a common sense of what's happening. You're planning to resuscitate, and maybe it's a CHF flare. What if we ultrasounded them first? Right. And you're sort of like allowing that uncertainty to sort of bubble up into the room. That can feel really hard when you're a junior leader because you're going to get dissenting opinions. And there's this feeling that, like, no, I have to be in command when I'm practicing being in command. But to the extent that you can let that feeling go and understand that you are, even as a leader, you're like the servant of the team and the patient, right? That you're sort of allowing the room to have a good vote in there for it. So, one thing you can do when you're teaching the juniors, right, is to ask them to vote like that. Right? Okay, you think this patient with abdominal pain has appendicitis. How sure are you? 0 fingers, 0% sure. 5 fingers, 100% sure. Give me a number. Well, why did you pick that number? Right? Well, tell me what you're looking
Mm.
at. And by expressing it that way, you're inviting them to share with you the under layer of their mental model. Right? Their mental model is appendicitis. The underlayer structure is, well, blah 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 blah. Right? And that's getting at that space that allows you to teach for it. There's a great version of this question that comes from Kevin Sear, who's a Royal Canadian Mounted Police SWAT leader, who says he often asks his juniors when they're presenting a plan, right? And their plan is like, we're going to attack this house or whatever it is, right? Okay, cool. Tell me what you thought of and didn't choose.
Mm.
Why didn't you choose that? Right? And again, you're asking these questions that aren't going head to head against what's happening. Instead, you're creating a space where people have the opportunity to dig in, explore, explain, and share some of their underlying thought structure with you, which is really part of your goal as a leader, right? Can you expose that underlying thought structure, stress test it, and make it better?
I mean, it's the leadership version of show your work, right? Like you're
Mm-hmm.
showing all of your work as to like why and how you got to the one answer or plan that you decided to go with. And I think that's really important because it's often just dismissed so early. You immediately come up with, here's my airway plan A, right? And yes, I have plan B and plan C, but we're not going to do those. It's like, well, hold on a second. Why? Like, why aren't you going to do plan B and plan C? Why aren't you going to do a bougie first, right? Especially like with me, I often try to set expectations before a shift and I often write down what learners are weak on and what they want to improve. And one is like, I want to use a bougie to intubate. And then all of a sudden they're choosing plan A, which has nothing to do with a bougie, right? And it's like, well, why, your plan B is a bougie. Why aren't you using that if you have already expressed interest in wanting to improve upon that skill? And so I think it's really important to kind of dig deep into the why and understanding, the reasoning behind not choosing that plan first as your plan. I think that's really huge.
There's a link here to something we said earlier, which is what can the system do to support you as you're learning to become that leader, right? So one situation that in academic centers we frequently find ourselves in is there's a very sick patient, either it's an intubation or a cardiac arrest or something going on, and there's a few other of us that are around. We're watching. We're not directly involved in the care of the patient at that moment, but we're sort of watching about it. So that's an opportunity for us as instructors to help the juniors think through not just what's happening, but the why underneath it, to your point. So, okay, you just saw your teammate do this. Why do you think they chose that? What do you think they could have chosen differently? Can you imagine a parallel scenario that's like this, but a little different, that would have made you pick a different path? What would make you do a different direction than what they started with? Right? And
Yeah.
you're using it as a jumping off point for exposing that sort of underlying logic structure in there. There was a really world-class gymnast that I spoke to at some point, Kristen Allen, who talked about when she was doing mental visualization practice for her tumbling routines, she would pay extra special attention to the points in time in her visualization when things felt fuzzy, right? When things felt a little bit off, like she wasn't really sure where her left foot was, or maybe the visualization tended to switch from first person to third person point of view in that moment, right? For her, those were signals that that's part of the underlying logic of movement that she didn't fully understand. And again, that's a weak signal that it's up to you to surface and bring to bear, right? So maybe you're looking at a cardiac arrest case and you're like, yeah, okay, totally. Like, of course I would, put the pads on and then, IVO2 monitor and all the stuff I know how to say. And, we're just reflexively trained to say. But if you start asking laterally and being like, well, why wouldn't you intubate this person? What would have to be different for you to pick a different path? All of a sudden you start getting at these little areas that like maybe you didn't really understand why they did that, right? Like maybe there's a piece of their logic that you don't actually have as good of a grasp on. And when you look at it quickly, it looks like you're doing the tumbling routine. But it's only when you really stop and dig into it that you're like, wait a minute, that part's fuzzy, or why is that fuzzy?
Yeah. That's that amplifying that signal that you're talking about.
Mm-hmm.
And it's really honing down to the exact specific piece of the signal, right? Or piece of the decision-making process and the whole plan that is really amplifying and bringing it to light. It's almost like you're turning up like the gain, if you will, right, on a microphone or on the EKG machine to better see
Mm-hmm.
what exactly is it looking like. And that's really, really hard to do in real time. And I think it requires a lot of intention, a lot of kind of situational awareness. And that was going to be a comment I was going to bring up to before when we were talking about like when do you ask that right question, is I think there is also a huge component of emotional intelligence and situational awareness where you need to be able to recognize what's going on around you in that specific example for when to ask a question. But in this
Mm-hmm.
particular instance of what we're talking about is like honing down that particular noise signal and recognizing this would be the time to do it and bring it to light and act on it, right? And not just recognize it, but to also have some kind of plan to do something with it.
Yeah, there's a natural rhythm to resuscitation, right? And in part, we know that because we
Definitely.
know CPR has 2-minute cycles to it. But even sort of if you ignore that for a second, if you're in a team that's running just an excellent trauma or a really good sick medical patient, when you start, everything feels like it's going crazy all the time and you're just sprinting, right? But when you get better at it, there's a sense of rhythm to it. There's a speed up and a slow down. There's a natural pause and breaks that happen. And if you don't look for those, you're not going to find them, right? So one
Yeah.
of the things I want my juniors to have on is this sort of extra radar in the back of their head being like, what's the rhythm of the room right now? What's the temperature? What's the noise? What's the rhythm? Are we sprinting or are we pausing? And you'll see folks when they don't get it because the room will have spun down a little bit and they're still moving at a million miles an hour and there's a disconnect in there. One of the best ways to start training this, I think, is usually in a trauma, there's a moment a few minutes in where there's a break for a chest x-ray, or a pelvis x-ray or whatever it is, right? And everybody steps out of the room for 1 second, right? Somebody's like, clear for x-ray, everybody moves out, and then there's a moment right there. That should be a moment where you can feel a pause in the rhythm and you can regroup. And maybe that's a moment where you take a deep breath. Probably that's a moment where you regalvanize the team around what your mental model is, right? And there's a sense in there, everybody steps out for x-ray, and now what, right? And that's the moment where you're like, all right, folks, I want to bring us back together. I think the most important injury is the penetrating injury to the left chest. We're going to look on this for a pneumothorax. If that's fine, then we'll move on to finish the fast and we'll get the patient to the scanner. Who sees a more important issue, right? Not are we good, right? But like, does anybody see a more important issue we got to tackle first?
I'll also broaden that for you. For those of you who don't work in a trauma center, it's immediately after you intubate a patient and get the x-ray. You could easily apply that same kind of model as opposed to it being so trauma focused. You could easily be like, did we intubate this for the correct reason? Did we intubate this patient for the correct reason? Are we missing any other, non-respiratory complaints that might have driven this patient to being intubated? Was intubation the right decision?
Yeah, that's a great example because there's also the phenomenon that's sometimes called the intern mic drop, right? Which is where the intern goes to intubate the patient. They successfully pass a tube and they're like, did it. And they drop the mic and walk out of the room. They're like,
Totally.
My job's done. And you're like, no, actually, that's the most physiologically dangerous point for this patient.
Yep.
Like, we know things will go bad in a few minutes here. And like, you actually have to train yourself to realize that's actually not the right time to pause, right? So, you sort of like, you have to balance that natural sense of rhythm with your expected sense of what's about to happen. And that's from the very beginning, we're talking about how moving from junior to senior is two stories. It's the story of you becoming a better provider and a better practitioner, and also the story of you learning how to lead a team at the same time, right? You're working on yourself even as you're working on your skill of leadership, and both of these things are going on in that moment.
A good example of something that's usually forgotten about after intubating a patient is just raising the head of the bed, right? I mean, that's like a bread and butter, like ICU prevention strategy for pneumonia. And oftentimes I'll know that the team was so rushed in getting out of the room when as the intensivist come down and be like, yeah, why is this patient still flat? Right? Like, they're not wearing a collar. They're not a trauma. Like, what was there another critically ill patient that I'm about to get consulted on where everybody had to just like run out of the room. Right. And so that's a really good point as to how there's so much more that happens after you intubate, and there's so much more that happens after you get ROSC. Like ROSC, I feel like is another one. You get ROSC and everybody takes a breath, and then especially if the pulse is really great and the blood pressure is improving, then people are like, okay, like we're good here. And you're like, no, actually this patient coded, like this patient died, and like now we need to like actually do a lot more work. And so that's, I think, another good example of that.
So to get like strategic or tactical about that point of view again, right? One of the things we're talking about is what is the cone of your focus? Are you tight focus or are you broad focus, right? Are you heads down operating on a thing or are you heads up looking at the field? And that tension between needing to narrow your focus, put your head down and do a task. You got to thread a 3mm wire into a 4mm dilator to get the central line in, right? You got to like actually get the bougie through the cords. Your entire zone of life is that really small, narrow focus in there. But once that moment's over, it's a leadership level senior skill set to immediately cone your focus back out and look at the rest of the field and the rest of the room again, right? So that's a thing that you can train. That could look like within a room, all right, everybody, we just accomplished this really major thing. Before we leave the room, 2 seconds, everybody look at your sphere of responsibility. What could go wrong in the next 5 minutes, right? Or it could be as you're leaving the room, right? You've just intubated the patient. You've got ROSC. Everybody has a plan. This was cardiac arrest for hyperkalemia as a likely cause. We fixed the hyperkalemia. We got them back. They're on a ventilator. We've got central access. Our plan is moved to the ICU. We're pretty packaged here. Okay, take a step back. Then it's the discipline of looking at the rest of the field and reminding yourself that you've been heads down in that room for 10 minutes. Now you have to run your board again, right? So we talked about broad brushstrokes, psychological safety, questions, hierarchy, clearing the path. And we've talked a little bit about small tactical things, changing the way that you ask questions. And to that list, I would add this, which is practicing zooming out, practicing opening up your focus when you leave one of these situations, like immediately afterwards. And just to
Yeah.
get like exquisitely tactical about it, like look at the part of the wall where the wall meets the ceiling. Like find a horizon line and watch yourself expand your peripheral vision across that horizon line. Just train yourself to do that when you're walking out of a room. That will actually improve your ability to zoom out and like take in the whole space.
Yeah, I mean, I think that like it applies not only to obviously the patient in front of you, but also like your list, but and the department as a whole, right? Like that's having that
Absolutely.
awareness all across the board, right? So I mean, yeah, I think we covered like a ton of stuff. I feel like we could talk about this stuff for like literally hours, and there's literally so many more episodes that we could do, from just this stuff. And I hope that we could bring you back for some more episodes because that would be a lot of fun.
That'd be awesome. Can I issue a challenge to people?
Please do. I
Yeah?
love these.
Oh, right
Go
on.
for it.
All right. So I always end my podcast on the emergency mind with challenges. And so I've gotten used to sort of doing this. The goal of this is that you like, if you listen to this conversation, you nod sagely to yourself and then go back to doing the same thing you're doing before, then Mark and I will have essentially failed to produce meaningful things in here other than having a good time talking about resuscitation, right? So what we hope is that you do something different from listening to this. And one of the key things that I've learned about leadership and about transitions in leadership is that you really have to become a scientist of yourself to do this, right? Nobody's going to really be able to teach you how to do this. We can give you goalposts along the way, but it's going to be up to you to figure out what works for you for it. So to do that, you have to start running experiments. So my challenge for you on your next shift, on your next rotation, whatever it is to explicitly run an experiment around leadership like this. Now, what does that mean? That means you have a hypothesis, something you're going to test. Like, hey, Dan says I should change the way I ask my questions to invite more negative feedback. Awesome. I'm going to try that. All right. I'm going to physically change the way I ask this question, and then I'm going to reflect on it afterwards and see what I thought. Did it work? Did it not work? If it didn't work, great. What am I going to try next? If it did work, how could I make it better? And to really close the loop on this, it's best to enlist the help of other observers to it. So Mark and I are working on a shift. Mark's the attending. I'm the junior. I'm going to start becoming a senior leader in the near future. Hey, Mark, I want to try something, right? I'd like to change the way I ask questions. Can you watch me today? And can we reflect on it for a couple minutes at the end of it and see what you think? Awesome. That's it. That's my challenge to you. Run some explicit experiment about that and just get used to the fact that, we can teach you the dose of amiodarone, but it's going to be up to you to figure out how to lead that team in that room. We can certainly give you guidelines, but ultimately you're going to find your style, your voice, your rhythm, and you're going to share that with the people around you. So you got to get started experimenting.
That's an awesome challenge. I mean, especially if people start implementing it right away after hearing this, like you can literally do it on your next shift because it's only going to help you not only manage a team better, but continue the shift from being a junior learner into a more senior leadership position. So super awesome, man. All right. Well, I think that's it for this episode of Rebel Mind. Subscribe, share, and stay tuned as we dive deeper into practical ways to care for ourselves so we can show up and take care of others. Dan, thank you so much for joining me, man.
Thank you. Thank you for having me.